we shall discuss about anatomical landmarks in both the maxilla and the mandible. When we talk about anatomical landmarks, we will be discussing three different points. One is the primary stress bearing area, the secondary stress bearing area, and the relief areas. Okay. Now, what are the various landmarks in the maxilla? The labial frenum, the labial vestibule, the buccal frenum, the buccal vestibule, the distobuccal sulcus, the alveolar ridge, then you have the incisive papilla, the mid-palatine raphe, hard palate, rugae, okay, the maxillary tuberosity, the hamular notch, fovea palatini are various maxillary landmarks. So here we have the incisive papilla, the mid-palatine raphe, and this is your fovea palatini. This is the posterior palatal seal, the hamular notch, maxillary tuberosity, distobuccal sulcus, buccal frenum, labial sulcus, labial frenum, the alveolar ridge, the hard palate, and the rugae area. Coming to the labial frenum, this is called as the labial frenum. It is basically a mucosal attachment from the vestibule onto the ridge. It is a fold of the mucous membrane at the medial line. Now, the main reason for recording this labial frenum is that it moves along with the movement of the lips. So, adequate relief should be given for muscular activity, and this will ensure proper denture seal. So, when you take an impression, you can see a notch. This is called as the labial notch. So, in the mouth, it is the labial frenum. In the impression, it is recorded as the labial notch. Excessive relief for the labial frenum can weaken the denture and enhance the chances for a midline fracture. So, in this is how a labial frenum is given. It will be thin, narrow and long, not a very wide frenum. Okay. Coming to the buccal frenum, this is the buccal frenum, and here you can see the buccal notch in the impression. Now, compared to the labial frenum, like we mentioned, labial frenum comes like this. It is thin, narrow and longer, whereas the buccal frenum will be kind of more fan-shaped or V-shaped and a wider notch. It is single or double folds of mucous membrane, broad and fan-shaped, moves with the muscles of the cheek during speech and mastication, and adequate relief for muscle activity and more clearance has to be given. Now, this is your labial vestibule. This area between the labial frenum and the buccal frenum, this is called as your labial vestibule. Now, this in the denture or the impression is shown as a labial flange. So, labial frenum to the buccal frenum is the extension. Mucogingival line limits the upper border of the denture. Now, you have to adequately record the depth and the width of this particular area. Overextension can cause instability and also soreness, and proper contouring gives optimal aesthetics. Otherwise, what happens is if this is too thick, it will jut out and it will look very unaesthetic for the patient. Coming to the buccal vestibule, it extends from the buccal frenum to the hamular notch. Okay, so this is your buccal vestibule. In the denture or the impression, it is shown as the buccal flange area. Again, this also has to be recorded with proper depth and width. Now, this is the reason why when you do a border molding, you would record both the width and the depth of the border molding. And it is preserved till the denture fabrication by doing or by pouring the cast after doing beading and boxing procedure. Coming to the maxillary tuberosity, the distalmost portion of the alveolar ridge ends in a tuberous area that is called as the maxillary tuberosity. It is usually the area which is distal to your position in after the third molar. So, in the impression or the denture, it is seen as a notch. This is the area of the maxillary tuberosity. This is seen as a depth or a notch. Distal end of the denture must have a coverage which gives both the stability and retention of the denture. Now, gross enlargement, if it is a bony or a fibrous enlargement of the maxillary tuberosity, should undergo a surgical correction. The area distal to the maxillary tuberosity, so this is the maxillary tuberosity, and the area where the mouth mirror is lying, which is distal to the maxillary tuberosity, a dip there, it is called as the hamular notch. One hamular notch, so if this is the arch, this is the maxillary tuberosity, papilla, mid-palatine raphe, palatini. Now, this area beyond the maxillary tuberosity is called as your hamular notch. Okay. Now, this area from one side to the other side, you draw an imaginary line, a straight imaginary line and a cupid's bow imaginary line. It forms your posterior palatal seal area. So, this area includes your posterior palatal seal area. The major function of your hamular notch is to locate the PPS area itself. Coming to the vibrating line, like we mentioned, this is the posterior vibrating line and this is your anterior vibrating line. Posterior vibrating line will be straight, whereas anterior vibrating line will have a cupid's bow shape due to the presence of the PNS, posterior nasal spine. Okay. Now, vibrating line is an imaginary line. It is basically marked at the junction of the movable and the immovable part of the soft palate. It is 2 millimeters anterior of the fovea palatini and aids in establishing the PPS. Distal end of the denture must at least be touching the vibrating line. So, this whole area between the vibrating lines, anterior and posterior vibrating line, is called as a posterior palatal seal area. What is fovea palatini? Can you see these two dots? That is called as fovea palatini. They are basically formed by the coalescence of several mucous duct glands. So, you have bilateral indentations near the midline of the palate and it is posterior to the junction of the hard and the soft palate and it aids in determining the vibrating line. Coming to the hard palate, you know, during formation of the maxilla, there are two plates, palatal plates, shells, of they are called the palatal shells. They come and fuse at the mid-palatine raphe. So, this area is called as your palate. Now, this is a primary support area of your maxillary denture, or it is called as your primary stress bearing area. Why? Because it has got a horizontal portion of the hard palate lateral to the midline. Now, in the maxilla, the secondary stress bearing area will be the rugae and your maxillary tuberosity. So, primary stress bearing area will be your hard palate and the the ridge of the alveolus, and the secondary stress bearing area will be the rugae and also the maxillary tuberosity. Alveolar ridge, again it is a residual bone with mucous membrane. Like I mentioned, it is a primary stress bearing area. So, primary stress bearing area will be your hard palate and the alveolar ridge. Secondary stress bearing area will be your rugae and the maxillary tuberosity. Coming to incisive papilla. Incisive papilla, usually in a dentulous situation, it is seen intaglio surface, that is on the hard palate just beyond your central incisor, between them inside. Elevation of soft tissue over the incisive foramen or the nasopalatal canine. It is on or labile to the ridge. Now, what happens if there is excessive force or an impingement which comes over the incisive papilla? It can cause burning sensation, paresthesia and pain. Thus, a relief is necessary. Therefore, your relief areas include, the first will be your incisive papilla. Next is the rugae. They are irregularly shaped rolls of soft tissues. They are basically secondary stress bearing area. There are crests and depressions which is present in the rugae. Next is coming to the mid-palatine. So, this is the incisive papilla as you can see, and this is your mid-palatine raphe. Okay. Next relief area will be your mid-palatine raphe. Why? Because it has got a thin mucosal covering and it is non-resilient. So if you do not relieve it, first, there is chances of soreness or pain. Second, there is a chance that the denture will fracture in the midline. So let's summarize. The primary stress-bearing area in maxilla will be your alveolar ridge and the hard palate. Secondary stress-bearing area will be your maxillary tuberosity and the rugae. Relief areas will be the incisive papilla, mid-palatine raphe, and also the fovea palatini. You also relieve at the fovea palatini area so that you do not impinge on the mucus glands. Now let's come to the landmarks in the mandible. Labial frenum, labial vestibule, buccal frenum, buccal vestibule, the buccal shelf area, retromolar pad, the pear-shaped pad, lingual frenum and the lingual vestibule. So you have the buccal frenum, buccal vestibule, it's the lingual frenum, lingual vestibule, buccal frenum, buccal vestibule. This is your buccal shelf area. You have your retromolar pad, the lingual sulcus, the lingual frenum. Okay? And this will be your ridge. Coming to the labial frenum. This is the area of your labial frenum. It is shorter and wider than the maxillary frenum. Adequate relief for muscle activity, that is especially the mentalis activity, is necessary. Now a proper fit around it maintains the seal without soreness. This is your buccal frenum again. Adequate relief for proper muscular activity, and also it ensures a proper denture seal. In the impression or the denture, it comes as a buccal notch. This will be your labial vestibule. Buccal frenum to the buccal frenum will comprise of the labial vestibule. In the denture or in the impression, it comes as a labial flange. Now, the overextension can cause instability and soreness. Muscle attachment close to the crest of the ridge limits the denture flange extension. Mucolabial fold limits the depth of the flange. It is important to record this in the adequate depth and the width. Proper contouring is necessary for adequate aesthetics. From the buccal frenum beyond is the buccal vestibule. Okay, that is where the buccal flange in the denture or the impression is seen. Extends till the retromolar pad area. Again, this is the area which will give the widest area in the impression, and to record the adequate depth and width, proper border molding is necessary. Coming to the buccal shelf area. In the mandibular cast, this is the area of your buccal shelf. Okay, this is your primary stress bearing area in the mandible. Mandible has only a single primary stress bearing area, and that is your buccal shelf area. Why? Because it is thick cortical bone, and secondly, it is a area which lies perpendicular to your vertical forces. That is, it is almost a flatter surface, so all the forces will go directly perpendicular to that area. So therefore, it is called as your primary stress bearing area. It extends between your external oblique ridge and the crest of the alveolar ridge. Coming to the external oblique ridge, it is a bony ridge which runs anteroposteriorly from front to the back, anteroposteriorly outside the buccal shelf area. So if this is the buccal shelf, this is where outside the buccal shelf, this is your external oblique ridge, anteroposteriorly. The denture border should be 1 to 2 mm beyond this ridge for ideal retention. This shows as a small groove in the impression. Okay. Coming to the alveolar ridge. Now, the residual bone with the mucous membrane is the alveolar ridge in the lower also. The crest of the ridge will be very thin. In mandible, the crest is a very thin area, so it is usually relieved. And the buccal and the lingual slopes of the ridge is the secondary stress bearing area. The primary stress bearing area being the buccal shelf area, and the secondary stress bearing area is the buccal and the lingual slopes of the alveolar ridge. The crest of the lower alveolar ridge is always a relief area. Coming to the retromolar pad, it is a triangular soft tissue pad which is seen at the distalmost portion. Now, posterior end of the lower edentulous ridge, it is the limiting landmark to determine the height of the occlusal rim or the teeth setting, and determines the height and width of the occlusal table. Coming to the alveolo-lingual sulcus. This is the alveolo-lingual sulcus. It is divided into three parts: anterior, middle and the posterior part. Now, it lies between the lingual frenum to the retromylohyoid curtain. Anterior region runs from the lingual frenum to the myloid ridge. Premyloid fossa is the premyloid eminence in the impression which is seen. Now, the border of the impression to make contact with the mucosa of the floor of the mouth when the tongue touches the upper incisors. Overextension causes soreness and loss of stability. That is the anterior region. Next is the middle region, which runs from the premylohyoid fossa to the distal end of the mylohyoid ridge. So, from lingual frenum till the premylohyoid area is the anterior portion. Premylohyoid till the distal end of the mylohyoid ridge is your middle portion, and beyond that will be your posterior part. The lingual flange extends below the level of the mylohyoid ridge. The tongue rests on top of the flange and aids in stabilizing the lower denture. Coming to the posterior region, the flange passes into the retromylohyoid fossa. This is the area of the retromylohyoid fossa. Now, a proper recording of the alveolo-lingual sulcus will give you a S shape. Starting from your frenum, it will give you a proper S shape of the lingual flange. Retromylohyoid space. Now, this area is the retromylohyoid eminence. This is the retromylohyoid space which is seen. The distal end of the lingual sulcus, it is the area posterior to the mylohyoid muscle. It aids in good seal. A proper seal at this area will give you good retention and stability for your lower denture. Now, coming to the mylohyoid ridge, it is the area of attachment of the mylohyoid muscle. It is sharp. Basically, this is the mylohyoid ridge. It is sharp and irregular, covered by the mucous membrane. Trauma from the denture base at this area can cause pain, and therefore relief is necessary. So, this is how the mylohyoid muscles are attached. Now, the floor of the mouth is formed by the mylohyoid muscle, and it lies deep to the sublingual gland in the anterior region and does not affect the border of the denture. Now, in the posterior region, it affects the lingual border in swallowing and the tongue movements. Coming to the genial tubercles, this is where the area of genial tubercles is there. It is the area of muscle attachment of the genioglossus and geniohyoid. It lies away from the crest of the ridge, prominent in resorbed ridges. If the ridge is very, very resorbed, only then the genial tubercles are highlighted in that area. In case it is prominently present, it requires adequate relief. Coming to the lingual frenum, it is a fold of mucous membrane which attaches from the base of the tongue to the supragenial tubercle, and it should be registered in function. Okay. So, these are the anatomical landmarks. Let's summarize them. In maxilla, what are the limiting structures? What do you mean by limiting structures? The structures which forms the border or the limits till where the denture should be extended. Labial frenum, labial vestibule, buccal frenum, buccal vestibule, hamular lodge and the vibrating line. So, you have the labial frenum, labial vestibule, buccal frenum, buccal vestibule, hamular notch and the vibrating line. So, this is the limiting structure in the maxilla. What are the supporting structures? The primary stress bearing and the secondary stress bearing areas. Maxilla primary stress bearing area is the hard palate and the residual alveolar ridge. Secondary stress bearing area is the maxillary tuberosity and the rugae. Next is the relief area. So limiting structures is done, supporting structures is done. Next is the relief areas. You have the incisive papilla, the mid-palatine raphe and the fovea palatini. Incisive papilla, mid-palatine raphe and the fovea palatini. When you compare with taking a master impression or the secondary impression, you can correlate that it is in this same area of the incisive papilla, mid-palatine raphe and the fovea palatini that we place relief holds before we take a master impression or a secondary impression. Coming to the mandible, the supporting structures is a crest of the ridge, buccal flange area, external oblique ridge, mylohyoid line, mental foramen area and torus mandibularis. The limiting structures is again the labial frenum, the labial vestibule, buccal frenum, the buccal vestibule and the alveolo-lingual sulcus and the lingual frenum. Okay. Primary stress bearing area in the supporting structures, the primary stress bearing area is your buccal shelf area on either side. Here is your external oblique ridge. This is your buccal shelf area, which is a primary stress bearing area. If this is the crest of the ridge, then the slopes will be your secondary stress bearing area. Okay. In the mandible, the slopes are the secondary stress bearing area and the genial tubercles and the crest are the relief areas. So this is mainly to be understood, especially while doing the impression making and also for proper movements to be recorded during the border molding and secondary impressions. Thank you.